Now in this session, we are going to discuss here the muscles of anterior abdominal wall. In introduction class, we have told you that if, for example, you are looking at your anterior abdominal wall, the first structure that you come across is the skin. When you remove the skin, you will see the two layers of the fascia, and both they belong to the superficial fascia. And out of this, one is called the fatty layer, that is called the Camper's fascia. Clean it, you will see the next layer, that is called the membranous layer or the Scarpa's fascia. We'll discuss that more in detail when we'll go to the scrotum and other things. But if you remove these three layers, the next three layers will be the muscles. And these muscles will occupy here the anterolateral aspect of the abdominal wall, the lateral as well as anterior. And these anterolateral aspect of the abdominal wall, in fact, will be occupied by these three muscles, one after the other. One will be the superficial, another is deeper or intermediate, and the third will be the deeper. That means it will be the deepest. So three muscles, in fact, will look like. You will see that they look like this. See, if, for example, you are watching in this muscle, see, this is the first muscle after you have removed the skin. Means if you have removed the skin, for example, this black color is the skin. Next layer that you are removing is the superficial fascia's fatty layer, which I'm giving this green color. And then after superficial fascia's fatty layer, you are removing the third layer. This is now the membranous layer, which I'm drawing below here. And when you remove them, these three layers, you will actually see the first among the three muscles of the anterior abdominal wall. And this is the muscle that is called the external oblique muscle. So we call it the external oblique muscle. This is external oblique. Now, if we look at the external oblique muscle actually takes origin from where? It will take origin from, because the abdomen anteriorly and laterally does not have any bones here, so it will actually take attachment either from the thoracic cage or from the iliac crest, or you say they have bones. And if you are actually looking at this, so this outer surface of the ribs, how many ribs? Lower 8 ribs. Means outer surface of the lower 8 ribs means rib number 5, you say 5 is outer surface. 6, 7, 8, 9, 10, 11, and 12. This will take origin. And if it takes origin from them, you see the fibers, initially they will remain straight, so its upper border will be free. So you see this. So fibers take origin from rib number 5, this is 5th, this is 6th, 7th, 8th, 9th, 10th, 11th, and 12th. This is floating ribs. So this takes origin from the outer surfaces of your rib number 5, 6, 7, 8, 9, 10, 11, 12. You see. So if these fibers are actually coming, you will see that these fibers coming from these ribs will straight away, you see that upper fibers taking origin from 5th rib, they will be almost horizontal. And gradually they will become oblique. And progressively they get more oblique, more and more and more and more. Until the 12th rib comes. And after the 12th rib, you see there is a gap. And after the gap will come the iliac crest. So you will see that the fibers are the musculature between the 12th rib up to the iliac crest comes, its posterior border will be free again. So its posterior border is free. Even its upper border is free also, because these fibers are horizontally running. As upper border free, and then its fibers are running initially more horizontal, then more oblique, more and more and more, till the iliac crest comes. And with the iliac crest comes, it will actually catch hold of the iliac crest outer border again. And outer border of the not entire iliac crest, interior 2/3 of the iliac crest, because the posterior 1/3 of the iliac crest will be for posterior abdominal wall muscles. So it will be for anterior 2/3 of the iliac crest, outer border only. Outer border of the interior 2/3 of the iliac crest, then the outer surfaces of the lower 8 ribs. And after that, you see that when iliac crest finishes here, lower border of, I say, iliac crest finishes, anterior suprailiac spine comes. Means after the anterior suprailiac spine, initially you see that if it's there, then immediately after that there is a gap. So my bone is actually cut here. The bone is not present. You see that, and then the pubic, after the ilium, pubis comes, and the pubic comes and it catches hold of the pubic tubercle. means its lower border will be free also. You see, this lower border will be free. So its upper border is free, its posterior border is free, its lower border is free also. And so lower border is free. So this free lower border stretching between anterior spine and pubic tubercle will become very thick. It's not just become thick, it enrolled also. So due to enrolling, it become thick. And when it become thick, you will call it a ligament. And this is called inguinal ligament. So inguinal ligament is just nothing but it is the lower thickened enrolled border of the external oblique muscle. And under that inguinal ligament, you see there is a gap of the bone. And this is the gap which will give, in fact, entrance to all the neurovascular bundles which will leave the abdomen, will try to come here into the thigh. Thigh means which part of thigh? Front of the thigh. Your femoral vessels come through this. Your femoral nerve comes through this. Even very important muscles, the flexors of your thigh or flexors of your hip joint, they in fact leave the posterior abdominal wall and they are coming here anteriorly through that gap under the inguinal ligament to enter here into the front of the thigh, forming part of the floor of the femoral triangle. So you see that this is actually something, this is the gap. So gap under the inguinal ligament. Many structures will come under this inguinal ligament gap here. So this is actually called the inguinal, it is called the inguinal ligament here. But you see that after getting attachment to all of them, all of these structures, these external oblique muscle in fact will come and will be coming initially horizontal, later oblique, more, till you reach here to catch hold of your iliac crest and the pubic tubercle. Then you will see that all the fibers in fact will come here and will join with the with the contralateral fibers here at the midline. And when they are coming here to the midline, in its attempt to come to the midline and merge with the fibers from the other side, when it reaches to the midline, in its journey, very close to midline here, or little away from midline even, they will convert into the fibrous tissue. You call this huge sheet of fibrous tissue as the aponeurosis. So you see this green color, which I have actually shown you here, it is the aponeurosis. Aponeurosis of external oblique muscle. And external oblique muscle aponeurosis. So on the other side, external oblique aponeurosis is also coming, and both of these fibrous tissue or the fibrous tissue, or you can say fibrous sheets, they join together to form here a very thick line. I say the white line, you call them linea alba. So the two sides, in fact, join together. And so linea alba is not starting from what's conventionally, not starting actually from the rib number 5, because the fibers start from rib number 5. This is in fact starting here from the tip of the zephyr process. And from the tip of the zephyr process, this becomes very thickened because the two side fibers are actually joining, and it is inserted here again to the upper border of the pubic symphysis. So this line is present here. This is called the linea alba, and linea alba is formed as a result of the union or the fusion of the aponeurosis of the two sides external oblique muscle. This is external oblique muscle leaf. But linea alba will be actually formed by the fusion of two-sided, not just one muscle pair, but you say that two more muscles also, two more pairs will come here to fuse in this linea alba. But this linea alba has been utilized here. But I told you that this inguinal ligament has reached up to the pubic tubercle. But we have to reach it. The linea alba goes here up to the pubic symphysis. So that means if you look at this now, this is the lower part of your external oblique muscle. This is lower part of external oblique, which we have shown you here. This is the muscle which is attached here to the iliac crest. It is anterior spine. This is inguinal ligament. This is pubic tubercle. I have told you that it is attached to the pubic tubercle here, but it should go here to the pubic symphysis. Means it is going to the pubic symphysis. Means after attachment here to the pubic tubercle, the fibers now curve like this and reach the pubic symphysis. Pubic symphysis means now they will merge the anterior part of the linea alba this time. But during this process, during this phenomena, you will see that a gap will be created. Means here is the pubic tubercle and here is the pubic symphysis. So a gap is created. This is a triangular gap, and this triangular gap name is a superficial inguinal ring. Superficial inguinal ring is just nothing but the triangular gap or the defect in the lower part of or the inferior medial part of the aponeurosis of external oblique muscle. And where you can feel the landmark is the pubic tubercle, and you can feel the pubic tubercle is just be above and medial to this. This is here. And it's under the cover of your three layers, obviously. Skin, superficial, facial, fatty layer, and membranous layer. And this will come. If you cut these three layers, you superficial inguinal ring, you can easily see. And from the superficial inguinal ring will come out some important contents. especially you are watching here the content that is called spermatic cord. It's just not spermatic cord. One more nerve in fact is coming outside here. Also one nerve that is called the ilium-guinal nerve that you will see that. But you see this is here superficial inguinal ring here. So for external oblique muscle, which is not just giving support to your internal to your fibers here or to your abdominal wall, but it is giving passage to certain important structures also, which are running within the walls and coming out here. So if this is present here, you can watch here. This is a spermatic cord which is coming out, and which spermatic cord which is coming out, for example, through the superficial inguinal ring. How many layers it will now will come across? Will encounter now 3 more layers from inside. First will be the membranous layer, then will be the fatty layer, then is the skin. And this is not just a spermatic cord. At the end of a spermatic cord is the testis. So that means the testis and the spermatic cord, they are coming. And they are actually pushing here, pushing the membranous layer, fatty layer, and the skin, and making them a kind of a pouch here on the undersurface of the inferior aspect of the abdomen. That means in the perineum. And this structure you call them scrotum. So scrotum is made up of the same 3 layers with some modifications of same 3 layers which are present in anterior abdominal wall: skin, fatty layer, and the membranous layer of superficial fascia. And who is coming? This scrotum, this testis and the scrotum will actually come here in the bottom of the scrotum. So this is something that you are watching in the external oblique muscle here. The external oblique is the upper border, you know that is free. Its posterior border is free between the 12th rib and the iliac crest. And this lower border is free between the anterior suprailiac spine and the pubic tubercle. But at the same time, when you reach to the pubic symphysis, you have to make here a gap, because gap will transmit here something that is called the spermatic cord. So if here is the pubic symphysis, here is the pubic tubercle, so there is a gap. And this gap, okay, it is formed by the aponeurosis obviously, but the base is having here a bony attachment. This means having here a bone, and the bone is nothing but the pubic crest. Means this triangular gap base is formed by the pubic crest. Immediately it has a pubic symphysis, and it has laterally the pubic tubercle. So this is a triangular gap, and its sides are formed nearby, and apex also formed nearby the fibers of the aponeurosis of external oblique muscle. So this is in fact something about your external oblique muscle. But if you will actually be removing the external oblique and now coming to the next muscle here, this is from superficial to deep, the 3 layers of the skin and fascia. 4th layer is this, and now the 5th layer will be this when you are passing the needle through. And 5th layer means the anterior lateral muscle is number 2 muscle here, and this is the muscle that is called the internal oblique muscle. So this is the internal oblique. And if the external oblique takes origin from the outer surface of your ribs, lower 8 ribs, and then obviously the outer border of the iliac crest, not the anything from the back side or from the lumbar vertebrae. So its posterior border was free. And similarly, you have seen this muscle. But if you remove these muscles and the fibers were oblique in such a way that as if you are putting your hand in the pocket and you see the direction of your fingers here. This is what we call here the direction of external oblique muscle. But the internal oblique direction is opposite here. Upward and so we say upward and backward here. This is downward obliquely and forward. This is upward obliquely and backward like this. So if, for example, you are comparing 2 fibers, one fiber of the external oblique and one fiber of internal oblique, they are crossing with each other at 90-degree angle. So it is like this. If you remove all the fibers, one fiber, so you keep one fiber of internal oblique and one fiber of external oblique, you see that all the fibers actually are oriented in such a way that they are crossing at 90-degree like this. So to make them more stronger, you see they give more strength to your anterior abdominal wall. And if, for example, outer surface of the ribs is utilized by the external oblique, not the inner, but the margin of the ribs will be utilized. Not just the margins of the ribs, but the cartilage is also. Whatever margin will be present, right from the pubic, from the xiphoid process tip, whatever margin is available. Margin is available, which margin? You see that costal cartilage, number 7. Then inferior border of the costal cartilage, number 8, because 8 is attached with the, articulated with the 7. Then costal cartilage, inferior border of the costal cartilage of the 9th. Then inferior border of the costal cartilage of the 10th. And then will be the tip of the 11th rib, the inferior border of the 11th rib. Then the tip of the 12th rib. Then the inferior border of the 12th rib. So this margin is called the costal margin. So this time internal oblique will actually catch hold of the costal margin. Watch this. If, for example, you are looking at this, See, this will be, this is the rib number 5, 6, 7, 8. Okay, the 7th means it will be the costal cartilage, lower border of the costal cartilage number 7, then lower border of costal cartilage number 8, then 9, then 10, then tip of the 11th rib, inferior border of the 11th rib, then the tip of the 12th rib, and then inferior border of the 12th rib till you reach on back here. Costal margin created. This constitutes the costal margin, and here the costal margin on the other side, joined at the tip of the costal cartilage as a deferred process, and then is the inferior border of the 12th rib. This all together will make here a circle like this. You call them thoracic outlet also, or you can call it inferior thoracic aperture. And diaphragm is in fact instituted there to separate the thoracic cavity above from the abdominal cavity below. So it is taking origin from here. You can say not taking origin, it is actually inserted here because its origin is from below. Like the external oblique muscle was origin from above and insertion is below, but this time it is actually internal oblique has the origin from below and insertion above. And means origin from below means this time iliac crest, but this time it's not just iliac crest because it's not just iliac crest. Which surface of iliac crest if it is? It is the intermediate surface of iliac crest because outer lip has been already utilized by external oblique. So intermediate surface of the iliac crest, which part of iliac crest? Obviously anterior 2/3 of iliac. Posterior 1/3 is for the posterior abdominal wall muscle. So this is here. Then if you will actually come here, we don't have just a iliac crest, we have already present inguinal ligament also because first muscle is already present. So inguinal ligament, so it will catch hold of inguinal ligament also. So it is taking origin from inguinal ligament, not full inguinal ligament. It will take origin from lateral 2/3 of inguinal ligament only. Lateral 2/3. So lateral 2/3 of inguinal ligament, iliac crest anterior 2/3, intermediate surface, and then the costal margin. This 12th rib will come, but between 12th rib and iliac crest, its posterior border is not free. Because posterior border of your external oblique was free, but its posterior border of internal oblique is not free. So posterior border of internal oblique is not free. Will it take origin from the lumbar vertebrae? Obviously not, because this anterolateral muscle is not posterior muscle. So what will happen? A lumbar fascia will come forward. A lumbar fascia will come forward. Muscle will not go back. The lumbar fascia will come forward and catch hold of the lumbar fascia. So it will actually catch hold of the lumbar fascia. So this is lumbar fascia. So now you can see it's taking origin from the lateral 2/3 of the inguinal ligament, intermediate surface of the anterior 2/3 of iliac crest, lumbar fascia, and now is the 12th rib here. It will take origin from this area whole. Now it will actually go upward, backward, and obliquely, upward and backward, and catch hold of all these things, means to the costal margin until it will reach the midline. And it will fuse with the similar fibers coming from the other side also to form the linea alba. So we don't have two linea alba. Linea alba first layer will be actually anterior. That was formed by the two-sided muscles from the external oblique. And next will be this. So both will get fused here to re-strengthen your linea alba. So linea alba is not a separate as such in layers, but you see that external oblique from the two sides is united together. And now the internal oblique also fused together from two sides here. A linea alba will become more thickened because of the accumulation of fibrous tissue. So here, this is what we call here the lumbar fascia here. But you see that if they are coming, this is true. But those fibers, especially those fibers which take origin from the lateral 2/3 of inguinal ligament, they are very important. If you see these, they are not going obliquely upward. In fact, they are coming in such a way that these fibers are coming a little bit horizontal and they are arching in such a way that they are forming the lower part of your linea alba, and they will be inserted here to the pubic crest here. You watch here. If you watch this, see this now. This is now your internal oblique, lower part of internal oblique, to show you the lowest fibers, those fibers which take origin from the inguinal ligament. Watch these. This is the internal oblique muscle, lower part. See the fibers, they are taking origin from inguinal ligament, lateral 2/3 of inguinal ligament, not the entire inguinal ligament. You see this medial 1/3 is still vacant. So these fibers are now coming and making an arch to be inserted here to the pubic crest here and be a part of now the linea alba and attached here to the pubic crest. Means if they are attached to the pubic crest, you can imagine that if they are attached to the pubic crest, so these strong fibers of with the lowest arching fibers will be under the inguinal superficial inguinal ring. Means if you are passing your finger through the superficial inguinal ring, you can have your posterior wall being formed by these lowest arching fibers. If you see that, if you are putting your finger, if you see this, if you put your finger through this, The next layer will be the internal oblique, but which fibers? These fibers will be just behind them. Means your inguinal, your spermatic cord will be supported by these fibers from behind. And if these fibers are from behind, so if all these things you are seeing here, so you don't have too many free borders present in your internal oblique. You see, your upper border is not free, your posterior border was not free. But you see that lowest arching fibers, which I was actually showing you, watch this here, lowest arching fibers, its lower border will be free here because its lowest arching fibers have the lower border free. Why? Because it was not taking origin from the full inguinal ligament, but only lateral 2/3, medial 1/3 is vacant. So under this lowest arching fibers, lower border, now you can put the finger through. Means if your finger passes through your superficial inguinal ring, your posterior wall is surely formed here by the lowest arching fibers, insertional fibers here, but little lateral, your finger obliquely will go under this lowest arching fibers of the internal oblique. And these lowest arching fibers of the internal oblique, they are in a crescentic way. That's why we call them fox. Fox means crescent. It's called the fox inguinal. Inguinal fox. Fox inguinal. Fox means crescent. It's a crescentic lowest arching fibers. Also, the internal very important because below their lowest, below their lower free border, we have a gap between the lower free border and the medial 1/3 of the inguinal ligament. And through that gap, why the gap has been seen and why the gap has been actually left here? The reason is that because through that gap or under the lowest arching fibers will actually continue the journey of your spermatic testis. And this testis will now be pressing your external oblique after this, and external oblique is giving them the triangular gap through the superficial inguinal ring. So this is actually present here. This is your internal oblique muscle. So internal oblique is present from, is important from this point of view. As internal oblique muscle is actually present from this point of view. And if, for example, I'm showing you your external oblique muscle, through which is passing your spermatic cord. So spermatic cord is not just passing through that, it is actually taking here a coating from this also. Means if green color is the spermatic cord, green is why? Because it is actually taking the aponeurotic fibers around it. It is making here a kind of a sheath. This sheath is called the external spermatic fascia. Means spermatic cord is in fact a set of neurovascular bundles, ducts and etc. Many structures here packed together by the fascia. Packed together by the facial coverings. And one of the facial covering, the last one obviously the superficial most, it is formed by the external oblique aponeurosis when it was passing through the superficial inguinal ring. So it is giving here a coating. It's coating not just to the superficial, your spermatic cord, but it is giving the coating to the testis also, because testis has emerged from superficial inguinal ring first, and then the spermatic cord comes. Means just like your fist, this is the testis, and your arm is will be your spermatic cord. So it is not just covered spermatic cord, but it's covering the testis also. This was the spermatic cord. This is called the external spermatic fascia. But before that, it has passed through the lower free border of your fox inguinal or the internal oblique muscle. So it will take facial covering from that too. And facial covering from that also. So it will be facial covering. It's not just facial covering because it's the musculature also here. That's why the muscle will also pass around this. So muscle passes around this means another spermatic fascia is actually being formed around this. This is called cremasteric fascia. You call them cremasteric fascia. It's not just fascia, but muscle also. And not muscle is not making here a covering around your spermatic cord, but around the testis also. So if, for example, with the testis, as I'm showing you the testis here, so this muscle will be looping around the testis also. And it's not just muscle, the fascia also. You call them cremasteric fascia. It's not cremasteric fascia, muscle as well. So we call them cremasteric fascia and muscle. From internal oblique. And which coating in fact came from the aponeurosis? This was external spermatic fascia. External spermatic fascia. That came from the aponeurosis of the external oblique muscle. This was something about the internal oblique muscle, fox inguinal, etc. But when you're looking at this, you see there's three muscles you have to see one after the other. This one, next this, And if you remove this, you will see this. This time again the ribs used. This time again the iliac crest used. And between the ribs, last rib and the iliac crest, there is a lumbar fascia used. All these fibers are used. But this time the direction of the fibers is different. It is transversely oriented here. And it's taking origin from where? You see the taking origin from, you can see here, it's not taking origin from the costal margin this time. Costal margin is already occupied by internal oblique. From inside the ribs, inner aspects of the ribs. But how many? Not the lower 8, but the lower 6. So it is lower 6 ribs will actually give attachment to these coming here. After the last rib inner aspect means the 12th rib, it will become visible. Visible means between the 12th rib and the iliac crest. Okay, the fibers are coming from the 12th rib and immediately catch hold of inner lip of the iliac crest. Why? Because intermediate surface and outer lip has been already utilized. How much of the iliac crest? Obviously anterior 2/3. But between the iliac crest and the 12th rib, the gap is there. No, this gap is actually already been filled by the lumbar fascia, so it will catch hold of the lumbar fascia. So lumbar fascia is giving attachment to the two muscles here at the area between iliac crest and the 12th rib. First off is the internal oblique, and now next is the transverse abdominis muscle. So you can say lower 6 ribs means this is 5 and 6. This is a 5, 6. So you can say 7, 8, 9, 10, 11, and 12 inner aspects in form of slips. And you know that lower 6 ribs are giving attachment to inner aspects to your diaphragms also. Diaphragm. 6 slips of diaphragm. So 6 slips of diaphragm and the 6 slips of your transverse abdominis muscle, they interdigitate with each other. Because diaphragm is going inside here. This is coming outside. So they are at the time of origin, they are interdigitated. So if you are example, you are watching in this, so this is actually living here. And from here, they are transversely running. If transversely running means they will actually be transversely running and they're proceeding towards the midline. And in the midline, similar fibers are coming from the other side also. They merge together from the Ziegfeld process up to the Ziegfeld process up to the Vivek symphysis, another linea alba is created. So not another linea alba. Linea alba will be now giving attachment here, being contributed here by the pair of transverse abdominis muscle also. So linea alba will be more reinforced. It's not just reinforced and hanging here, above it is attached here to the tip of Ziegfeld process and below is attached to the upper border of Vivek symphysis. So it is stable also. It's giving attachment. Why? Because in the middle we don't have any bone. So we don't have any bone, we form the raphe. And such type of a raphe is a pretty, you say, reinforced here because the 3 muscles from one side and 3 muscles on the other side, they have fused together to form here. So 6 muscles, they will fuse together in the midline. 3 from here and 3 from other side here. Similar 3 from contralateral side to form here the linea alba. But watch it here in this internal oblique. So internal oblique, it's not just iliac crest, but it will also take origin from inguinal ligament. But this time inguinal ligament not 2/3, but just 1/3. And then it will take origin from the inner aspect of the inner lip of the iliac crest, then from lumbar fascia, and then from the inner aspects of lower 6 ribs. And from here all, it will now have a transverse course until reach the linea alba. But like the internal oblique, the transverse abdominis, those fibers which took origin from the inguinal ligament, in the internal oblique, lateral 2/3 of inguinal ligament, but in transverse abdominis muscle, lateral 1/3 of inguinal ligament. These have the same behavior. Watch it here. You saw this here also. And you saw this here. Now watch it here. This is now your transverse abdominis muscle, transversus abdominis. And these muscles are now coming. If they are coming, you see this, it takes origin from iliac crest, okay? And now it is taking origin from lateral 1/3 of only. You see the length of inguinal ligament giving origin to your internal oblique and the length of inguinal ligament giving origin to your transverse abdominis. See the behavior of this and see the behavior of this, similar behavior. So behind them, behind these fibers are also running. Because these lowest arching fibers of your transverse abdominis muscle, they want to reinforce the lowest arching fibers of the internal. So they are in fact coming in such a way, though their width is little reduced here, not like this, but width is little reduced. So they are actually coming like this. So they are coming behind them. If they are coming behind them, I have cut here to show you the insertional fibers of your lowest arching fibers of your internal oblique here, internal oblique muscle. And now these are the fibers which are deeper to them. This is transversus abdominis muscles, lowest arching fibers. So lowest arching fibers of transverse abdominis muscle passing behind the lowest arching fibers of the internal oblique, and they are going to get inserted into the same pubic crest. So these fibers of the internal oblique at the time of insertion, and these fibers of the transverse abdominis muscle at the time of insertion, they get fused here to form here a double thickness of these lowest arching fibers here. And this double thickness means that they both are joined together. So this tendon is called conjoint tendon. And you know that if it's a conjoint tendon, so that means this is superficial inguinal ring. If you are passing your finger behind the superficial, through the superficial inguinal ring, you are passing your finger means actually you are passing your finger means something is coming out. So it is passing your finger here and you are pressing behind, your posterior wall will be formed by not just internal oblique lowest arching fibers, but also the lowest arching fibers, the insertional fibers of transverse abdominis also reinforced together. So you say conjoint tendon. Means if you are putting your finger through the external oblique, its posterior wall will be formed by conjoint tendon. Means where superficial inguinal, where the external oblique muscle has a defect, the two muscles will give the reinforcement from behind. Become double from behind to, in fact, compensate this defect, compensate the bad or harmful effect of this defect. So superficial inguinal ring, here defect, here double strength to give strength to your anterior abdominal wall lower, so that your superficial inguinal ring from behind will be reinforced. So the viscera cannot be pushed easily through this. So if this is now here, when the superficial inguinal, so this transverse abdominis, so the lowest fibers of your arching fibers of your transverse abdominis muscle, its lower border will be free again. And so lower border is free, so until your inguinal ligament comes, a big gap is created. This big gap which was created here, there was a gap also, but this gap was a little smaller between the lower arching fibers of, why it is smaller? Because 2/3 of inguinal ligament was actually occupied by internal oblique. So the last fiber actually was like this. So gap is small. Because the last fiber was this, so the gap is big. And this bigger gap which you are actually seeing here, it is here. So this lower arching fibers of your transverse abdominis muscle is also called falx inguinal. Actually, this transverse lowest arching fibers and lowest arching fibers internal oblique together is called falx inguinal, and their insertional fibers together is called conjoint tendon. Both them will be called as a conjoint tendon. So conjoint tendon is constituted by the fusion of the lowest arching fibers of internal oblique and transverse abdominis. Those lowest arching fibers which took origin from the inguinal inguinal ligament here. So here see that. So that means a gap was already there. Superficial inguinal ring. Gap is already there between the falx inguinal and the inguinal ligament. And gap is already there between the lower arching fibers, you see, between falx inguinal of transverse abdominal muscle and inguinal ligament. So gaps are there. So means obliquely this gap will actually be going. If you are putting your finger through the superficial inguinal ring, it will actually be going under the falx inguinal fibers of internal oblique, then falx inguinal fibers of the transverse abdominis muscle, until you will reach in such a way on the lateral side, few centimeters on the lateral side, and now if you are pressing behind posteriorly, you will come across the facial coverings. The facial covering means next three facial coverings. Out of this, the first one, and that is called the fascia. This is called fascia transversalis. So you see, if you have removed this, you see this. If you remove this, you will see this. And if you remove this, you will see just nothing. You have got the fascia. This is called fascia transversalis. And this fascia transversalis, if you pressurizing the fascia transversalis, you see you have got a cushion-like a softer thing that is called the extraperitoneal fat. 3 layers of the skin fascia, 3 layers of the muscles, and now 3 layers of the fascia again. And fascia means fascia transversalis, extraperitoneal fat, and the last will be the parietal peritoneum. Means it will be very soft, because under that will be just the extraperitoneal fat, and then is the epithelium, and after that there is a peritoneal fluid, and floating within the peritoneal fluid, hanging inside the mesenteries, are the GIT structures. And if, for example, you are watching in this, so here this is your fascia transversalis, because you are passing your finger through the external oblique, say through the superficial inguinal ring, your finger will pass under the arching fibers of your the falx inguinal of oblique, and then under the falx inguinal of the transverse abdominis muscle. But the falx inguinal are the lowest arching fibers of the falx inguinal are the transverse abdominis muscle will be too high. So your finger will not be touched by them. If your finger is not touched by them, means your finger is not touched, means what is present there is not your finger, obviously it is spermatic cord. So your finger will not touch, means your spermatic cord will also not touch, so it will not get any contribution from your transverse abdominis muscle. So no coating at all. So will it have just 2 coatings? No. out of these three layers, when your facial covering, means fascia transversalis is coming, your finger will pass through fascia transversalis. Means in the fascia transversalis, there is a gap, there is a hole. And that hole is present where? That hole is present just, you say, 1 inch above the midinguinal point, means at this level. 1 inch above the midinguinal point. And there is a gap. Your finger will pass through the gap. This is called deep inguinal ring. So that means if your finger passes through the superficial inguinal ring, you have entered into intramuscular cleft. And if your finger passes through that, here superiorly it is bounded by the falx inguinal. Inferiorly it is bounded by inguinal ligament when your finger is inside here. If your finger is inside here, anteriorly by, anteriorly by your external oblique muscle, and posteriorly by fascia transversalis. Okay, above by, you see, if you are putting here your finger above, it will be falx inguinal. Below, you see this is inguinal ligament. And if you are pressing anteriorly, you will have external oblique, and if you are pressing posteriorly, you will have the fascia transversalis. All these are the boundaries of that intramuscular cleft, which will go obliquely and which started, and where my cleft will finish, where my finger will pass through the deep inguinal ring. And when it will pass through the deep inguinal ring, my finger will touch now, the tip of my finger will touch the extraperitoneal fat. Means the things are coming from extraperitoneal fat. It's not your finger is going, something is coming through this passage where your finger is there. So you will imagine that your finger is actually between these muscles. And your finger is from superficial inguinal ring until your deep inguinal ring. And in a cleft it is present, in a space it is present, and that is space where your finger is, actually it's not your finger, it's not the cord is there. And that cleft is called inguinal canal. So if the cleft is called the inguinal canal, so you can say inguinal canal stretches between the superficial inguinal ring and the deep inguinal ring. Means deep inguinal ring will be present where? Deep inguinal ring will be present around which location? Around the location you see that is like your midinguinal point. Under that, it will be present here. Yeah. So here should be obliquely under your superficial external oblique muscle should be this canal. You can call it the inguinal canal. So this inguinal canal is present here from superficial inguinal to deep inguinal. When you are pressing here, you see forward here, it will almost everywhere it will be external oblique muscle. Everywhere it will be external oblique muscle, and when you are pressing behind, almost everywhere it will be fascia transversalis. And when you are pressing upward, falx inguinal, and pressing downward, inguinal ligament. This cleft is called inguinal canal. But you see that posteriorly throughout it will be surely fascia transversalis. But when it has gone into the fascia transversalis, something is coming out of fascia transversalis, obviously. And that was the spermatic cord and the testis. So it will get a coating from fascia transversalis. So first coating, it will get it from fascia transversalis. And that is called now, this blue color which I am showing you, this is called internal spermatic fascia. Means it is first is the internal spermatic fascia. Next it will be muscle, that is the transverse abdominis muscle, but its lower border is so high that it will not give any coating. Yes, it will give the coating. Which one? The internal oblique cremastic fascia and muscle, and the last coating will be given by the external oblique muscle. This is called the external spermatic fascia, and these coatings are not given just by the these layers of these three structures, that is external oblique, internal oblique, and fascia transversalis to the spermatic cord, but to the testis also. So the scrotum, when a testis is present, three coatings are those of the scrotum itself, and three coatings of these three structures here. Three structures means two muscles, not all three, but two muscles, and one wall from the superficial, one was from the fascia transversalis. All these coatings, in fact, will be surround the testis as well as the spermatic cord. And here is the inguinal canal, which you are actually watching here. So that means when you are passing your finger through the external oblique superficial inguinal ring and pressurizing behind, in the medial 1/4 only, these conjoined tendon fibers will also be present. Not just the fascia transversalis posterior wall will be formed in the inguinal canal, the posterior wall will be formed by, because when you are putting your finger in the superficial inguinal ring, means your inguinal canal is started. And anteriorly, external oblique, obviously, but posteriorly, fascia transversalis, but in the medial two-third, or the medial, I say, medial one quarter of your superficial, of your inguinal canal, it is formed by fascia transversalis, though, but it will be conjoint tendon also. Why you need in the medial one quarter of your inguinal canal, you need a reinforcement of your posterior wall by the conjoint tendon? The reason is that because in the anterior wall of the inguinal canal, there is a defect. To compensate the defect, we need actually the conjoint tendon behind. But you see there, okay, here is our deep inguinal ring in the posterior wall, in the fascia transversalis. Why don't we have a reinforcement here now in the anterior wall? When in the posterior wall there is a defect, you need the reinforcement in the anterior wall then. If the anterior wall was having a defect, you need the reinforcement from posterior wall of the inguinal canal. So when there is a hole here in the inguinal, I say in the fascia transversalis, which is the posterior wall of your inguinal canal, then we need the reinforcement from anterior wall. And anterior wall formed by external oblique throughout. But under the external oblique, we have lowest arching fibers of your internal as well as of the transverse abdominis muscle. Means here was our somewhere here I'm giving dotted because not in this internal oblique. Under that we have transverse abdominis. Under that we have got here. So that means here is the gap. This is called the deep inguinal ring. Means if you are putting your finger in the deep inguinal ring, if you are anteriorly you are pressing, it's not just the external oblique which is present. Under the external oblique in the lateral most one quarter, we don't have just anteriorly external oblique, but we have reinforcement from internal oblique and transverse abdominis. This is the conjoint tendon of oxyguinal we call it. So that means when the anterior wall most medially has a defect, this is the superficial inguinal ring, then the posterior wall will not just be formed by fascia transversalis, but it will be reinforced by the two more muscles, this is called the internal oblique and transverse abdominal muscle. This is conjoint tendon which was giving the support. And when you are going, this is only where, means throughout the entire length it is external oblique. And this through entire length it was external oblique. Here through entire length the posterior wall was formed by the transverse fascia transversalis, but in the lateral one quarter posterior wall was reinforced by conjoint tendon also. Why? Because the anterior wall has a defect to compensate this. And when you are going laterally, you see here, we have a deep inguinal ring, and deep inguinal ring, posteriorly we have just a fascial transversalis, but anteriorly we have throughout entire length it was having external oblique, but on the lateral side, just in front of your deep inguinal ring, there was a reinforcement of your external oblique with the conjoint tendon of oxyguinal. Means these fibers are actually giving the support here. Why? To compensate the weakness in your deep inguinal ring. This is the mechanics of strength, or you can say reinforcement of your deep inguinal ring and superficial inguinal ring to give strength to your anterior abdominal wall defects. These are the two defects, and these defects are compulsory. Why? Because we need to actually travel, to make the testis and their neurovascular bundles travel through this gap. And through this gap means your finger is passing through, and now you are touching your finger to the internal, say, deep inguinal ring, and now you are pushing inside. You have external extraperitoneal fat, and the extraperitoneal fat is actually lying your aorta, inferior vena cava, lymphatics, etc. And testis also develops there. And testis starts descending from extraperitoneal fat. And the testis descends from extraperitoneal fat here down into the scrotum. So all these walls have to be crossed here. And always remember 9 walls, the 3 from outside, skin, fatty layer and membranous layer, they will bulge to form the scrotum. Then 3 layers of your anterior lateral muscles, say the external oblique, internal oblique, and transverse abdominis, and then 3 more layers deep to them. This will be actually 7, 8, and 9. 7 will be the fascia transversalis, 8 will be the transverse, say, extraperitoneal fat, and 9th will be the last, that is the peritoneum, parietal peritoneum. And after the filled water and huge cavity comes where they will start there. We will discuss and we'll see them in the next class. What are the mechanics of spermatocarp, how the testis descends, and what will be the clinical aspects related to your inguinal canal here.